Hi everyone, my name is Jean and I'm a clinical dietitian and certified nutrition support clinician in Chicago. I'm also a member of the Dietitians and Nutrition Support DPG, and today we'll be talking about how to manage electrolytes in TPN. So today we're going to cover the first set of electrolytes, so that will be sodium, potassium, magnesium, and phosphorus. In a later video we'll talk about calcium and then chloride and acetate balance because those are a little bit more involved. So there's some information to consider before we start kind of doing the math, of course. So the process starts by becoming familiar with your patient, as usual, and their medical, surgical, and nutrition-related history. If we're starting from scratch, so a new start on TPN, which is what we're going to do with this case study today, it's best to start with identifying baseline electrolyte needs and then adjusting up or down based on what you know about your patient. So we have to consider electrolyte input sources and then also electrolyte outputs. So inputs are any sort of intake, right? So IV writers, IV fluids, although these are usually discontinued once TPN starts. And then electrolyte outputs. So is the patient losing a lot of electrolytes from sources like NG suctioning, vomiting or diarrhea? Do they have drains? Do they have a wound vac? Do they have an ostomy? Something else to consider is, are they a dialysis patient? That kind of throws us for a little bit of a loop. And then are they on any medications that could affect their electrolyte balance? For example, diuretics, either potassium sparing ones or loop or thiazide diuretics, which are more potassium wasting. All right, so to introduce you to a couple of the references we'll be using, these are both from the Aspen Core Curriculum, the 3rd edition, which is the most recent one. So we're gonna look at this table of volume and average electrolyte content of gastrointestinal secretions, and we'll reference that because this is one of the main sources of electrolyte output that we'll consider. And the next table is daily electrolyte requirements. And this is, again, in the Aspen Core Curriculum. I believe the source is a JPEN article. And I use this as kind of a guideline for when I'm starting TPN, where to start in terms of electrolyte dosage. So let's go ahead and start with our case study. Our patient is a 50-year-old male. He weighs 72 kilos. He is NPO, so no oral intake. He's on D5 normal saline at 50 milliliters per hour, and he has an NG tube to low intermittent suction. And over the first 24 hours, he had 1 liter of output. So we're going to talk first about sodium. If we refer back to our table of GI secretions and their electrolyte contents, we can approximate that in this 1 liter of NG tube output, our patient lost about 60 milliequivalents of sodium. So we need to account for that as an output. Now let's think about input. So the patient is receiving D5 normal saline at 50 milliliters per hour, which is equivalent to about 1.2 liters per 24 hours per day. We know that normal saline has a sodium concentration of 154 milliequivalents per liter. So 1.2 liters of normal saline will provide the patient with about 185 milliequivalents of sodium in that 24-hour period. So to get what we are calling the net amount of sodium that the patient's getting over this 24 hours, we need to subtract the outputs from the inputs. So the patient got 185 milliequivalents from the normal saline, and we're subtracting the 60 milliequivalents that were lost from the NG output. So we're calling this a net positive 125 milliequivalents of sodium over 24 hours, or from yesterday to today on our labs table. So if we're looking at yesterday's labs, his sodium was 136, and today it's 137. So it increased from 136 to 137, and it still remains on the lower end of a normal range. Usually we're aiming for the middle of the normal range or around a serum sodium of 140. So we can continue to provide a net positive of about 125 milliequivalents of sodium per day and see how the labs trend. As the dietitian, you're going to want to communicate with your interdisciplinary team that we should be discontinuing IV fluids in most cases when we start TPN. We should also be following up with nursing regarding the patient's NG tube output. Is it increasing? Is it decreasing? We need to know that information so that we can estimate what we think the output will be over the next 24 hours so that we can adjust our electrolyte content of our TPN to account for these predicted losses. Okay, so in bag number 1 of our TPN, which is going to hang today in reference to our labs table, we chose to put 160 milliequivalents of sodium. The next morning, i.e. day 2, nursing reports that the patient's NG output decreased to 800 milliliters over 24 hours. So that equates about 48 milliequivalents of sodium lost. So if we're subtracting our outputs from our inputs, we're going to subtract 48 from 160, and that is giving us a net positive of 112 milliequivalents of sodium. And if we look at the labs for day number 2, the patient's sodium was steady at 137. So we decide to keep the amount of sodium same in bag number 2, which is going to hang in the evening of day number 2. So we're going to keep that 160 milliequivalents. On the morning of day 3, nursing reports that our NG tube output has decreased significantly and was only 300 milliliters over the past 24 hours, which is equivalent to about 18 milliequivalents of sodium lost. So if we subtract outputs from inputs again, so we're subtracting 18, the output, from 160, the input, we get a net positive of 142 milliequivalents. On the morning labs on day number 3, the patient's serum sodium increased to 142 from 137. So providing a net positive of 142 milliequivalents might be a little bit too much for this patient, as it did increase his sodium by 5 milliequivalents in 24 hours. If we kept the sodium level the same, theoretically tomorrow his sodium would increase by another 5 milliequivalents, which would put it at 147, and he would be hypernatremic, which we don't want to do. So we decided to reduce the sodium in the TPN to 120 milliequivalents in the bag that will hang on the evening of day number 3. So the next morning, day number 4, we talked to nursing, and they state that the patient's NG tube was removed, so there's no more NG output that we need to account for. The serum sodium on day 4 is 143. So it seems like we've kind of figured out what the patient's baseline sodium needs are now that his serum sodium is stabilizing and we no longer have GI output to account for. And if we refer back to the table from JPEN on baseline electrolyte needs, a baseline sodium requirement of 120 milliequivalents per day for a 72 kilogram man falls between 1 to 2 milliequivalents per kilo, so that makes sense. Great, so a couple things to consider when we're looking at sodium in our TPN is, does the patient have any IV fluids running or were they discontinued? So like I mentioned, IV fluids tend to be discontinued when TPN is started. However, this could be overlooked or just kind of forgotten about. So keep an eye out on the medication list and make sure that if the patient has IV fluids running, that everyone on the team is aware of that and that it's intentional. Additionally, we have to be cautious with sodium because rapid changes, whether up or down in serum sodium, can have severe neurological consequences. So a rule of thumb generally is that sodium should not change by more than 6 to 10 milliequivalents over 24 hours, but always defer to the managing physician on these numbers and see kind of what kind of rate of correction that they're looking for. All right. Moving on to our next electrolyte, which is potassium. So we're going to go again through this same case study starting with day 1, but we're going to focus on potassium instead of sodium. So we have the same patient, 50-year-old male, 72 kilos, got an NG tube to low intermittent suction. So again, let's refer back to our table of GI secretions and their electrolyte contents. So we can approximate that in 1 liter of GI secretions, this patient lost about 10 milliequivalents of potassium from the NG output. We're also noting in the chart that the patient got a 40 milliequivalent rider of potassium chloride. So if we're doing our inputs and outputs math again, we have input of 40 milliequivalents of potassium from the IV rider, and we have 10 milliequivalents of output from the NG tube. So the patient has received a net positive 30 milliequivalents of potassium over 24 hours, or from yesterday to today on our labs table. His potassium actually dropped a bit from 3.7 to 3.6, So if we're aiming for the middle of the normal range, or a serum potassium of about 4.0, we'll need to provide significantly more than 30 milliequivalents per day. So as the dietitian, you need to communicate with the team regarding how much potassium you're providing to the patient. This will help them decide if they need to provide additional IV riders. And if the patient is on dialysis, a good person to talk to would be the nephrologist who is managing their dialysis. They might want a specific amount of potassium in the TPN, or they might want a stable amount so that they can better dialyze the patient and better predict what they're going to need to do. In bag number 1 of our TPN, which will hang today in reference to our labs table, we chose to put 70 milliequivalents of potassium, or approximately 1 milliequivalent per kilo, which is on the lower end of that dosing range if we refer back to our dosing table. The next morning, so day 2, nursing reports that the patient's NG output did decrease to 800 mils over 24 hours, which is about 8 milliequivalents of potassium lost. So again, we subtract our outputs from our inputs. So we subtract 8 from 70, and we get a net positive of 62 milliequivalents of potassium. And if we look at the labs for day 2, the potassium increased back to 3.7 from 3.6. So still on the lower end, but in the normal range. So during multidisciplinary rounds, so we're calling this 10 a.m. on day 2, the team discusses adding a 40 milliequivalent IV rider of potassium chloride. So we know the patient has only received about 50% of the first bag of TPN, because in most places TPN hangs at night. So we're saying that they got TPN from 10 p.m. until the point we're at now, which is 10 a.m. So they've only received half of their 70 milliequivalents of potassium. So we communicate this to the team, and they decide to reduce their order to a 20 milliequivalent rider. We continue with 70 milliequivalents of potassium in TPN bag number 2, again, which hangs in the evening of day number 2. On the morning of day number 3, nursing reports NG tube output decreased to 300 mils over 24 hours, so about 3 milliequivalents of potassium lost. So we subtract outputs from inputs. So we have 70 milliequivalents of potassium in the TPN and the 20 milliequivalent IV rider that the team added yesterday. And then we're subtracting the 3 milliequivalents that were lost in the NG output, and we get a net positive of 87 milliequivalents. On the morning labs on day number 3, the patient's serum potassium has increased to 4 from 3.7 the day prior. So this tells us that potassium of 87 milliequivalents is probably near the patient's baseline needs for each day. Could be a little bit high, so it increased his potassium from 3.7 to 4 in 24 hours. So if we run 80 milliequivalents of potassium in the TPN bag and suggest that the team holds off on additional IV supplementation, we can see if we've closely approximated the patient's baseline needs. On the morning of day 4, nursing reports that the patient's NG tube was removed, so we no longer have output to account for. The serum potassium on day 4 is 4, and it seems like we've figured out what the patient's baseline needs are, now that his serum potassium is stabilizing and we no longer have GI output to account for. So if we refer back to the table from JPEN, a baseline potassium requirement of 80 milliequivalents per day for a 72 kilogram man falls between 1.2 milliequivalents per kilo, 1 to 2 milliequivalents per kilo, which makes sense for baseline needs. A couple things to consider in terms of potassium is that in most cases, I'd say it's probably better to be cautious than aggressive, as potassium can always be supplemented with additional IV riders. However, hyperkalemia is dangerous and requires intervention immediately. Additionally, we should consider the patient's renal function, whether or not they're on dialysis or if they have acute kidney injury and are potentially not excreting potassium as well as they normally do. We also should consider if they're on diuretics, and specifically which type of diuretics. So if they're on something like Lasix, which is not potassium sparing, so they will excrete more potassium, we may want to consider an additional 10 milliequivalents per day on top of what we consider their baseline needs to be. But again, that's just something that should be managed between you as the dietitian, the pharmacist, and the medical team. All right, let's talk about magnesium now. So if we look back at the JPEN table, baseline needs for magnesium are around 8 to 20 milliequivalents per day. Magnesium is not largely present in gastric output, so we don't really need to account for it if we're talking about NG tube losses or other sources of GI output. So on the labs yesterday, the patient's magnesium was 1.7. The team gave him a 2-gram rider of magnesium sulfate, and for each 1 gram of magnesium, it's equivalent to about 8 milliequivalents. So his magnesium increased to 1.8. In bag number 1 of TPN, we're going to choose to include 20 milliequivalents of magnesium, 20 milliequivalents of magnesium. On day number 2, the magnesium comes back at 1.8. So in most situations, an ideal serum magnesium is around 2.0, so we want to bump that number up a little bit. We increase the magnesium in bag number 2 of the TPN to 24 milliequivalents, and the next day, the serum magnesium is 2.0. So we decide to keep the magnesium at 2.4 since it seems we've identified his baseline needs, and the next day, the magnesium comes back at 2.0. So a couple things to consider with magnesium, actually just mainly one thing to consider, is that low magnesium will impede your ability to effectively replete the serum potassium because magnesium is implicated in renal excretion of potassium. So if you don't have enough magnesium, your kidneys will not be able to do their job properly in terms of retaining adequate amounts of potassium. So you can provide IV riders of potassium until you're blue in the face, but if your magnesium is low, you're not going to do much in terms of correcting the potassium. And our final electrolyte for this gentleman is phosphorus. So if we look back at our JPEN table again for baseline needs, phosphorus is in millimoles, and it's about 20 to 40 millimoles per day for the average adult. So on the labs yesterday, the patient's phosphorus was 1.8. The team decided to give him a 15 millimole rider of sodium phosphate, and his phosphorus increased to 2.0. So in bag number 1 of TPN, we chose to include 20 millimoles of phosphorus. So just kind of an arbitrary number. We picked on the low end of the baseline requirements because we saw that with an addition of 15 millimoles, that increased his phosphorus by 0.2. So by giving him 20 millimoles, we're hoping to increase it by a little bit more than 0.2. So on day number 2, the patient's phosphorus comes back at 2.2. In most situations, an ideal serum phos is around 3, so we want to bump that number up a little bit. We increase the phosphorus in bag number 2 of the TPN to 32 millimoles, and the next day the serum phos comes back to 2.8. So we decide to reduce the phosphorus in the TPN to 28 millimoles, and we find that that keeps the phosphorus steady at 2.8, and thus we can determine that his baseline phosphorus needs are around 28 millimoles. And then one thing to consider with phosphorus, which we can talk a little bit more about in the next video, is that calcium and phosphorus, when at certain concentrations and at certain pH levels, have a propensity to precipitate, which is not something that we want to happen in TPN. So sometimes phosphorus takes precedent, and we might not be able to always fit calcium in the TPN. Again, that's something that we rely on our friendly pharmacists to help us with. And then one more thing to keep in mind when you're looking at lab values and managing electrolytes in TPN is that when are your labs drawn compared to when does your bag of TPN hang? So if your morning labs at your hospital are drawn at 5 a.m. and your hospital's TPN policy is that TPN hangs at 10 p.m., technically the results of those morning labs will be reflective of only 7 hours of the current TPN bag, so what infused from 10 p.m. to 5 a.m. So it just adds another little twist in to try to manage electrolytes in accordance to the patient's lab values. So now that we've covered sodium, potassium, phosphorus, and magnesium, stay tuned for next video, which will be covering calcium and then also chloride and acetate balance, so acid-base status in the TPN. If you have any questions about this video or about electrolyte management and TPN, please leave them in the comments below and we'll get back to you as soon as possible. Thanks for watching and we'll see you next time.